ahead and get started. So
We're ready?
Hey everybody, good afternoon. Yeah, good afternoon. Tracy Jones, if you don't know me, I'm the Executive Director of Blair Chiropractic Technique. And we just started these weekly meetups, not just for our members, but for anyone in chiropractic that might be interested in Blair or any of the topics that we're covering. This is just a time that we all need to unite and realize that we are stronger together, and it doesn't matter if you're a member, if you practice Blair or another technique, we are all here for each other. So we do want to offer these, and we do offer them weekly on Thursdays. They do vary from time to time, but we are excited to have Dr. Jake Hollowell here. He is from Brazil, and he is our resident CBCT expert. As you could see on our advertisement, he had a little fun with Photoshop there. So welcome, Dr. Hollowell, and you can take it away.
Okay, well, thanks. So I live in Brazil. I'm from the good old America, just to kind of clear up some confusion, you know. Although my English is probably a little bit broken now that I've been out of the country for over 11 years now. But anyways, thanks a lot, Tracy. In fact, speaking of my clever, this is actually my associate that did this one. He's much better at it than I am. But I want to thank Tracy also because she does a lot of work for our Blair Society and upper cervical in general. And without her, we would all be lost. So let's go ahead, and everybody can hear me, everybody can see my screen. If there's anything that you can't see or it's breaking up, just let me know. Let's see. Okay, so the first thing I wanted to cover was actually some software troubleshooting, because probably the biggest questions I get are from other chiropractors that are having some trouble with the software. So I'm just going to briefly go over a few of the most common errors that occur. So one that happened to me recently, because I'm now using the newest version of the CS3D program that I could download, and it does have a few bit of bugs. But what was interesting is I was opening it up with the images, and this image was popping up. Now, this image is in Portuguese. My computer doesn't speak English; it speaks Portuguese. But you can kind of more or less guess. It says it's not functioning. It's not responding. There was some sort of problem, and I tried to open the program, and it gives me this sign, and then it won't open the image. And as I often do, some of the students that I've had that I've taught the CBCT imaging analysis, they've had the same problems, and a lot of times I look for them to find a solution, and they tell it to me, and then I tell it to everybody. So one of my students in Brazil had this same problem occurring. And what we found was that it was nothing to do with the software. It had to do with the RAR opener, what opens up the compacted images, because I receive all my images from the imaging center and they're compressed. So I have to decompress them to open them up. And what was happening was that the file manager archive here wasn't opening. And so without the file manager, that error comes up. The other thing that can sometimes happen when you're decompressing a DICOM image, a CBCT DICOM image, is sometimes when the imaging center or another chiropractor uploads it, whether they send it via Google Drive or whatever it is, Dropbox, sometimes not all the DCM files will load. So that's another common problem. So you can see here on this list, there's 643, 644, 645. It has to have all these numbers in sequence, or when you try to open it, it'll give you an error message. And so the newer problem that I had recently, and it was weird because it happened exactly the same moment that I installed the new version of the CS3D program, which is actually much faster. It's got a few new functions. But for whatever reason, at that exact moment, from that moment on, when I tried to decompress images, I started to get this error message, which we showed right here. Okay, so you always have to make sure there's a file manager. And if for whatever reason you open a file and it doesn't have the file manager, but another one does, you can actually just copy the files manager from any archive or any DCM image and put it in the pasta. Pasta is the word for a folder in Portuguese. You can put it in the folder, and it'll automatically work. So that was the newest technical difficulty that I've seen, and that's how you solve that technical difficulty. Has anybody else had this problem, or is it just here in Brazil that we have this problem? Nobody's shaking their head or saying anything, but you're welcome to speak up. Don't be shy. Anyway, so that's one. The other thing is that some people, oh, Jake, I got an image and the image is upside down. So when you request an image from an imaging center or another chiropractor, if you don't have CBCT in-house, it needs to be in a dicom multi-file format. It can't be in a single file format. So what I just showed you with all these files is a dicom multi-file format. There is another format where it's just one DCM file, but the CS3D, at least the older versions of it, we're not able to open up the single file format. Okay, so it has to be a multi-file format. So that's another big problem. So here it is. Here's what it would look like if it's a single file. It'll actually be upside down. And I've actually had chiropractors try to analyze it upside down. It'll give you a headache. It'll subluxate you. So I suggest not to try to analyze the image upside down, please. Okay. Other thing that some people get hung up on is when you open up the program, it'll come up with this screen and you just have to hit ignore. So pretty simple fix. And then the last thing that's also a very common error that chiropractors tell me about is that they're not able to visualize the three-dimensional image. So this can be due to the fact that they do not have a good graphic card on their computer. In that case, they will need to purchase a new computer. A good computer, you can get a really, really good one nowadays from between 800 to 1,500 American dollars. So not too much in comparison to other equipment that we have as a chiropractor. And I would always suggest getting one of these newer computers with a good graphic card so you can see the image. So one thing may be that the graphic card is not ideal. Now let's say that you do have an ideal graphic card, but the 3D image isn't showing up. So it could be one of two things in that case. One, you may have to go into the graphic card control panel. So one of the most common brands of graphic card control panel is NVIDIA. So I've gone into the control panel. You can usually, if you go to the right corner of your computer, it'll have a little icon. You can right click and go into the control panel. Or if you're on Windows, you can go into search and type in control panel, graphic card, or whatever the name of your graphic card is. Get into the control panel. It'll usually have a screen that appears like this. There's global setting, there's program settings. Go into program settings, go to add, find the program. It'll look like this, program files, parentheses, x86 / CareStream. You'll add it, and then you need to select the high performance NVIDIA processor. Okay, and then go into the bottom right corner and hit apply. You have to hit apply. Somewhere on the screen will be the button OK or apply new settings. So that's the other big thing that chiropractors have difficulty with. Okay, and not just chiropractors, I guess anybody that will be using this program. I'm just, because I teach mostly chiropractors, that's why I'm saying that. Okay, the other thing that you may need to do, so let's say your computer has a good graphic card, the graphic card control settings are all up to snuff. The next thing you would need to do is go into the settings on your computer, on the CS3D program. On the top, it'll be this little gearbox, okay? And then click on the 3D icon. So you can see here it's blue. It's the second from the left. Oops, my thing is going forward for me. And I set it like this: speed, quality, balance, enhanced hardware, accelerated rendering. So it needs to have all these things, all these boxes checked, just like I have on the screen here. And then you'll hit apply, and then everything should be working. Okay, so those are the basic things if your 3D image isn't showing up correctly. And there was one of my students asked to show me how to calibrate the 3D, so I'll do that at the end of this presentation. Let's go in. I had a really interesting case that came in recently, so I'm going to show you kind of a sample oddball case. It doesn't really follow any of the normal rules, and I think it's good to kind of show you how to take care of a case that doesn't follow the normal rules. So here we have a to P view, P to A view, because left is left and right is right in this view. So one of the first things I do, one of the other students in the CBCT group asked me, well, how do I look at images? So this is kind of my thought process, how I analyze an image. So one of the first things I do is I'll open up this P to A view. I'll put a slice thickness adequate to see the structures that I want to see. So in this particular case, it's 40 millimeters. And so I just kind of look at it, visualize, and the first thing I'm going to do is correct head tilt. And the reason I do that is so that the next parts of my analysis are correct and there won't be variables. The other thing I want to note is if there is a short or long condyle, which is very important in the Blair work. So here we have a short condyle on the left and a longer or a taller condyle on the right. Not a big difference, but it's noticeable. And one of the things Dr. Blair found was that a short condyle can create 4 innate adaptations. And in this case, we see a kind of a slight lateral curvature. I wouldn't call it a scoliosis, but you can see a slight lateral curvature. And this is due to the shortened condyle on the left. Why is this important? Well, this will let me know that this adaptation or this patient, they may never have a straight or orthogonal neck due to this short condyle on the left. This adaptation, this curvature, is most likely due to the shortened condyle that we see on the left side. So next, I just I decrease the slice thickness just so you can see the short condyle and the long condyle more clearly for those that are new to the Blair work. And so here I'm looking at 1 millimeter slice thickness, okay? Next, I'm gonna go to an axial view. I like to have around 33 or 36. For whatever reason, I put 36 millimeters. Some cases, maybe 26 or 28. Once again, you wanna get a thickness of the area that you wanna see. And for me, I get to see the foramen magnum. I get to see the atlas and the whole entire posterior arch of the atlas in this view of this thickness. So that's why I choose this thickness. Now, what I've done with this line that's 175 millimeters is I've drawn a line through the ears. In Blair, we use the ears to mark our sagittal plane line, all right? And I also just wanna show you, and I want you guys to visualize what's going on here. So if you just look, once again, left is left and right is right. If you just look at the foramen magnum and you look at the posterior arch, you can kind of see from this view that the posterior arch has shifted to the right. If anybody disagrees, feel free to unmute your computer and yell at me and tell me what you think. But for me, I can clearly see that the posterior arch has entered into the foramen magnum to the right. Now, if you look, if you can see, I don't know, I think our pictures are covering up the right side of the screen, but I've accounted for the head tilt that we had in the previous pictures. So I've switched this whole plane so that it's parallel to the inferior portion of the foramen magnum, the inferior portion of the condyle, I should say. Okay. So this axial view, which is our base posterior, I've accommodated the head tilt so that I can see the atlas without any distortion. If I didn't do this, then I would see a distorted view of the atlas. All right. All right, just for those that are curious as to how I select the point of the ear mark, it's maybe a little hard to see on this one, but there's kind of this little cartilage mound here. And that's what I use, and I find that it goes very well in the center of other structures that other techniques may use. In Blair, we use the ears. Other techniques have their different parts of the hard palate, you know, different parts of the nasal sinus, all different things that they use. I've checked everything, and this little cartilage bump in the ear, for me, gives excellent results. But if you use a different technique, one of the orthogonal techniques, use the structure that your technique taught you how to use. But for us, it's this little, I kind of highlighted it here, this little cartilage, little part of the cartilage in the inner ear, or the middle part of the ear. Okay, so next, we've now switched to the curved slicing tab in the CS3D program. And I'm just going to show a quick video of how I analyze. Now, recently people have asked me, well, in the personalized cuts, there's a tool that you can use to do a TMJ analysis, and you draw two lines. And so there's some chiropractors, especially some of the Blair chiropractors, that they want to get it right along the convergence angle, because there's that kind of sweet spot on the convergence angle where you could see what we call underlap or overlap. Once again, I've done that in the past, and it's okay to use that. I like to look all the way around, because for me, that gives me more information. Because there's some of these oddball cases, which I'm going to show you right now, that it's good to see what's happening all around the articulation. Because Dr. Blair used a very good analogy. He said that, you know, he used the analogy of a nut, and particularly a walnut. And the two halves of a walnut shell should always fit together. You could have two different nuts, and they may have, you know, different shapes, but the two halves of one nutshell should always fit together. And that's kind of the same analogy that he gave for the articulations that form in the body. And this is basic embryology. We all know that that's at least what happens when you're a young child. As we grow older and as we degenerate, yes, the articulations may not fit together exactly due to wear and tear and different movement patterns. But when we're a young adult, they should fit together, and then this is basic embryology. So I like to look all the way around the joint because for me, this will give me more precise and more specific information. And so I'm going to go ahead and play this video now and show you why I prefer this method to other methods that could also be done. I just feel that this gets me better information. So here we are, we're looking at, I think, the right side. I can't see because my fat face is in the way of the right corner. I think we're on the right side here. Okay, and so we're looking at, here's the occiput, and here is the atlas. You guys can see my mouse? Okay. So here I am, I'm right at the middle point on the right side, and we see a little bit of overlap. But if you looked on this case, when we were on the more anterior portion, it looks like it's almost even. Yeah, and that's why I like to look all the way around. So next, I think we're going to go to the other side. We're going to go back again to another point. So this will be kind of the sweet point that would show up on most of the, if you did a typical Blair analysis using the typical protractive view. And so you can see it was a little bit of an overlap, but in the front of the joint, it's almost even. So
yeah, it's the same one. It's the same one that you printed off last time.
Okay. So next, we're going to go to the other side. We're going to go to the left side, and we're going to look at the left side. And so here, I'm going to pause this for a second. Here's something that can drive some people crazy, where there's not a very clear margin of the occipital condyle. You can see it's kind of got this weird thing going on in here. And this is why I look at several slices. I will never just get a listing from one slice. That's why I like to look all the way around. And by looking all the way around, you'll get an idea of what's actually happening. Because sometimes on this margin, there may be a part that didn't form, maybe it stayed cartilage, maybe it didn't ossify completely. There's a bunch of things that can happen that we're discovering that we can see with the CBCT image. And so this is on the left side. It looked like it would almost be an overlap, but it's kind of got this weird thing going on. And when you look at the other slices, it shows that it's relatively even. And just in this one little area, there's kind of what I like to call a divot. For those that play golf, they know what a divot is. So it's kind of like this little divot that forms, and it's kind of some sort of anomaly or malformation. And so that's why, once again, I like to look all the way around and not just in one point that would be indicated if you were to do just a traditional convergence angle analysis and a traditional protractive view analysis. All right. Continue playing. Okay, so once again, here's this kind of this divot in the margin of the occipital condyle. And then when you go back, once again, it gets even. Okay, when you go in the front, once again, it's even. It was just that little area that kind of had a malformation, and the rest is even. So this, for people that are new, this is the first time you looked at a CBCT. It's gonna be confusing. We can't cover a whole CBCT course in the time period allotted today, but I just wanted to show a few things to get people interested in it, and then we can do more of these Zoom meetings in the future for those people that will be in quarantine for the rest of your life. So what we found here is that there was overlap, but only on the lateral margin of the right side. So in this case, the atlas didn't move forward, it actually moved more just to the right. So it's kind of just a right laterality in this case. And this is a thing that I see in some cases. It's pretty rare, but I will see it sometimes 3 times in a month. Sometimes I won't see it at all in a month. So it's something to be aware of. Okay, so what we're looking at here is, if you look up in the top right corner, above the picture of my head, at least on my screen, it's above the picture of my head, you'll see that I'm on the back side of the right atlantal occipital articulation. And here we can see just a little bit of overlap, right? Very little. So here's the margin of the condyle, of the occipital condyle, and here is the portion of the lateral mass. There's a little bit of overlap that we can see there. On the left side, in that same portion, it's even. And once again, this is the reason why I like to look all the way around the articulation. I want to get as much information as possible in the case that there's some sort of weird anomaly that there was in this case. This particular misalignment doesn't follow the normal Blair pattern of misalignment where it's tracking along one. It's basically, it's just slipped directly to the right. And if you were to twist your head, you may actually see just a little bit of underlap, and that would also back up this hypothesis that in this case, the vertebra hasn't gone anterior, it's just gone right lateral.
Okay, can you just kind of toggle that usually?
Yeah, so in those cases, it's just a toggle, no torque, because for me, in my biomechanical understanding of the Blair adjustment, the portion of the torque is more for the anterior component. And so because there is no anterior component, it's just a straight, good old toggle, as specific as possible, as quick as possible, as light as possible. All right. So here's what it looks like from the back. When I take pictures of their posture as well. And so in her posture, she had this same head tilt. And once again, remember from the views before, we had a short condyle on the left. So she made a head tilt for her, maybe her normal posture. All right. It's a possibility. Obviously, we'll do a reevaluation, a progress exam, and we'll see how everything is changing. So, but here's what it looks like in 3D from the back. And I will show you at the very end how I calibrate, because a lot of people can't calibrate the 3D image very well, and their image comes out a little bit frosty or foggy or not as clear, not a good resolution. So I'll show you how to do that at the end. All right, so here is the left view, the left lateral view. So I always will look at the position of the styloid process. I'll look at if there's contact on the arch, on the transverse process, and then I'll look at the rest of the articulations on the left. So that's the first thing. And I'll also always look and see if there's any issue with the TMJ joint. All right. So here I'm just going to play a video of the analysis in 3D. So once again, just kind of showing you what I would look at. Look at all the pillars, the articular pillars, and see how they're lined up or not. See if there's any malformations. I'm going to zoom in. And so on the 3D, it looks like maybe the atlas might be a little bit anterior, an ALS in the Blair listing system. I'm going to go to the right side. And here's a tricky one, because it's kind of got this weird articulation on the top of C3. It's round, and then the top of C2 is straight. And so, and here's what it looks like from the top. So you have to be careful when you look at the bird's eye view down the neural canal. Depending on how you tilt the head, you may get bad information. I was able to tilt the head very well and just kind of get an idea. So in this view, we can once again see that the atlas has shifted to the right in relation to the foramen magnum. If we look at C2, it's shifted to the left with respect to the atlas, and to the left with respect to the third cervical, which is this ring a little bit farther below. Okay, so once again, I wouldn't use this per se to get a listing, maybe just to back it up, maybe just as an interesting thing to look at. But in this case, I'm just kind of pointing out some things. But once again, if you don't tilt the head correctly, it's going to give you information that can confuse you. But in this case, just what I'm seeing, the atlas has shifted to the right and the C2 to the left. Okay. Now, here's what it looks like in the NPR. So I've accounted for head tilt. So here we see the second cervical vertebra. In relation to the atlas, it's once again shifted to the left. And then the atlas is once again a little bit hard to see, but it's still shifted to the right. Okay, but the second vertebra shifted to the left. Right. Here I've gone down a little bit farther, and once again I've accounted for any tilt in between the second and third vertebra. You can see this on the right side of the screen. So I'm not, in this axial view, it's not exactly perpendicular to the bottom of the image. It's perpendicular to the articulations between C2 and C3, because what I found is this will give me better information. If you purchase the CBCT manual, you'll hear me say a lot of times, I like to look at a lot of different views. I'm not someone that just looks at an image for 5 or 10 minutes and then I'm ready. I look at it for a lot longer. I'll go back and look at it. I like to double check, especially on these cases that aren't as straightforward. And this case is one that's not as straightforward as some other cases. But anyways, what we can see here is we can see the big spinous process of C2, and it's shifted to the left with respect to C3, which is this more narrow ring. Okay, C2 usually has a big spinous process, and the one below it is C3. So C2 is shifted to the left. So there's a shift in the neural canal between C2 and C3. Okay, so one of the things I'm next going to do is I'm going to look at the articulations, because in Blair, what gives us the listings of C2 on top of C3 would be the actual articulation, not these neural canal views that I'm showing you. These are just things that I use to back up. So you can measure the thickness of any structure. So here it's about 10.5 millimeters, the articular pillar, the facet. So that's going to be the thickness that I'm going to select for the next view. So I've selected 12 millimeters because I just want a little bit more than 10.5 millimeters. Okay. So what I want to point out here is a few things. First, look at the top. So here's the lanceoloccipital articulation, and you can see that it's pretty well lined up. It hasn't gone nor anterior nor posterior, or either anterior or posterior. Okay. It looks pretty lined up. So the next, we're going to go to the C2, C3, C3, C4, C4, C5, C5, C6. I like to look at the 3D image to get the misalignment, but there's a lot of chiropractors, and it's actually very intelligent, that they like to look at this black and white view because they can actually see the articular surface if they know how to tilt the image correctly. So one of the problems that chiropractors may run into when looking especially at C2 and C3 is that the C2, C3 articulation tends to be in this configuration, meaning it's not parallel with the ground. It's not in the horizontal plane. It's a lot of times it's tilted. All right, and I'm going to show you exactly what I mean by that, because you can't really see the margins of the articulation very well on this view. Okay, here's the other side, the same thing, you can't see very well. So here's the left side, right side. It's kind of cool when you have it all lined up like this because you can kind of see the movement. Okay. And once again, here's the right side. So we're looking again at the anterior portion of the lanceoloccipital articulation. And there may be a slight 0.5 millimeter anterior, but it's pretty well lined up. All right. Because a lot of times if it was anterior, you would see this part, it would shift anterior. All right. So here's the right facet joints. So what I was talking about earlier is that the articulation between C2 and C3, a lot of times it has this configuration. So what we're looking at is a posterior anterior view. So this is the left articulation between C2 and C3, and you can see it's got this angle. So if you want to see the actual articular surface in its best view possible, you're going to have to actually tilt the plane so that it's more parallel with the joint surface. And you may have to play around with it a little bit. It may not be exactly parallel. You may have to grab this little ball and tilt it a little bit here, a little bit there, until you're able to see the articular surface between C2 and C3. All right, so now here is the left C2, C3, and see this little white margin? Now it's much easier to see the articulation. And you can see on the left, actually, they line up pretty well. If you were to tilt your head to the left like this and squint your eyes, you may see that it's a touch anterior, but it's fairly lined up. Whereas on the 3D view, it looked like it was for sure going to be an ALS, an anterior C2 with respect to C3 on the left. Okay, but you can see the articulations here, they line up, they're the same length. So this is the left side. Now, here's the right side. So with the right side, we always want to look at the anterior portion of the articulation. Okay, so once again, what I've done here is the same thing that I did on the left, I just did it on the right. Okay, so here I am on the right. Now, it will be very easy for chiropractors to look on the back part and say, well, for sure it's gone posterior. But there's a lot of things that can happen. And you can see kind of how this white structure here, it's about the same length as the other one. I actually measured it, so it's about the same length. But as I say, when we're a kid, the articulations will line up really well. As we start to have subluxation, as the movement patterns of the articulations change after they've been subluxated for a number of years, you're going to see that sometimes this little white sclerotic margin may not always line up exactly. And I'll give you an analogy. It's kind of like the difference. I live on the beach. I like to surf, do all that stuff. They finally, oh, good news. This week they let us go back to surf. They said we couldn't surf because, I don't know, a high risk of catching coronavirus out there on the waves. Never mind, I'm not going to get into it. Back to the CBCT. But anyways, so you're on the beach, right? So it's the difference between you sticking your foot from directly down and making an imprint in the sand, or you're sitting on your chair and you're rubbing your feet back and forth. Well, the same thing of articulation. When they're originally formed, if there's no irregular movement pattern, they will line right up. But after several years of having a subluxation and irregular movement patterns, you may often see that the inferior articulation has a wear pattern that's slightly larger than the superior portion of the articulation. That's usually the pattern I see. Because there's some distractors to Blair that will say, well, we did a test and we found in cadavers that the articulations didn't line up. And they use people that were like super old. And they said, well, yeah, we've proven it. That's not right. Well, no, you didn't prove it. You proved what you wanted to prove. You proved your narrative. But I've looked at a bunch of these images, and Dr. Blair was pretty spot on. So, and that's not to say that other techniques are wrong. It's just to say that there's a lot of science to back up what Dr. Blair was saying. And if you want, ask me a question. I'd be glad to show you an example of what I'm talking about. But here we go. So back here, so we can see that the C2, this is on the right articulation. So this is C2 and this is C3. And you can see that the C2 has shifted ever so slightly posterior on right here in comparison to here. Okay. So once again, those that are new to the Blair work, this may go over your head. Those that have been doing the Blair work for a while, hopefully this makes sense. If not, let me know and I'll try to explain it in a different way. All right, so here I have measured it. So the top is 9.4 millimeters, and I've measured the actual, the portion of the articulation, and it's also 9.4 millimeters, maybe 9.5. I could have maybe gone a little bit more. But once again, a lot of times the inferior articulating surface over time will become a little bit larger than the superior portion. Yeah, but that's it. So what we're seeing here is what we would call a posterior left inferior listing, or PLI. And there may have been a slight ALS. So we have a listing that's called ALS PLI, where it's gone slightly anterior here and slightly posterior on the other side. And that's actually how I chose to adjust this person, with an ALS PLI. Okay, so that's the end of that. And I adjusted her. She had 10 degrees. I used a hip caliper. She had 10 degrees of tilt. She had 1.5 centimeters of short leg that she thought was just, she'd always thought she'd had it. Since a kid, she thought it was an anatomical short leg. And after the adjustment, all indicators cleared out really well. So how I ended up adjusting her, not something very common. Once again, it's pretty rare, but lately, for whatever reason, I've been getting these cases. So I adjusted her C2 ALS PLI, waited a little bit, rested her a little bit, and then I adjusted her a right toggle listing. And what I did was I just tilted, I tilted the head a little bit to the left, to get it so that it was in more of an even position, so that the articulation wouldn't jam. I don't want to jam the articulation. And so I did a C2 ALS and a right toggle on the right transverse, and everything cleared out. Her hip cleared out, legs cleared out, muscle tone cleared out, and she had that kind of get up and whoa, I didn't think that was going to work, and it worked. So one of those kind of instant that we're on the right track. Obviously, she just started. We'll follow up, and I'll let you know how that's going. All right, so I'm gonna get out of this PowerPoint. Anybody have any questions on what we just covered? I know for, if this is your first time looking at CBCT, some of this stuff may be a little bit complex, but at least gives you an idea of what we can do with this technology. Anybody have any questions?
Jake, can you show the lateral views again?
Yep.
No, I saw the 3D image.
Yep. Yeah, let me go. Actually, I have the image open. Let me go ahead and I'll open it up. And
Jake, I found these finer points really helpful. Thank you.
okay, no problem. Good deal. It says my screen sharing is paused, so I'm going to resume share. I'm going to close this. Can you guys see my screen?
Yep.
Okay. So here I have the 3D image. All right, I think it was Kevin that was asking to show the 3D image. So here's what it looks like on 3D. So it looks like a pretty clear ALS, right?
Yeah.
So you can either,
Jake,
you can see
we're
it.
still seeing the PowerPoint. You got to do a new screen share to show a different window.
Okay, let me see how to do that.
When you go down to the screen share button, you hit the arrow to the right, and you can
Yeah.
select a different window to screen share.
Okay, the arrow to the right. I'm going to stop share, and then I'm going to try it
Okay.
again.
There you go.
There we go. That's my
There we go.
technology. I turn things off, I turn them back on, they work. That's how it goes. Okay, so everybody can see the 3D view. All right, so here we go. So here's the 3D view. I'll kind of turn it around, let you look at it. So with this one, you can see the articulation. And so it goes to right about here. So then if you kind of visualize that and turn back, you can see that it's probably right here. So it's not as big as we thought. So it's not this point up here. You see how we can see the circle of the articulation, because the articulation here is pretty round, right? So you can see it. So if I turn it back and keep it, it's an ALS, but it's pretty small. It's smaller than originally it looks like if you just look at it really quick. Okay, and on the right side, it almost looks like it's an ARS. I mean, this is kind of a tricky one. But because I've done so many other backups and it showed me that the C2 has shifted to the left in respect to both C1 and C3, because everything, I had a number of indicators that showed me that that's what the case was. I had no problem adjusting it with the C2 ALS kind of PLI adjustment. Yeah, I mean, and once again, this is a weird case. It's an oddball case. We don't, but you know, sometimes you're going to get one of these, and so I'm just kind of showing you how I look at it. Any other questions with regard to this 3D image?
What was the age of the patient?
What's that? The patient was born in 71.
Okay, so about 49.
Yeah. Okay. So that's that. So a lot of people, I think the last thing we're going to cover, and then we'll let everybody go on with their day. And if there's any other questions, I'll answer them at the end. But the last thing that people have a lot of difficulty, and it's not easy, it takes a lot of just playing around with, is how do I get the 3D image to look pretty like this? Well, depending on what machine the image came from, it's going to change from one or the other. But I can tell you, you can send me your image and I can help you with it and help you calibrate it. But I'll show you more or less what I do. So the first thing is you're going to go to the 3D adjustments. Once again, for me, I like to look at bone in this kind of straw color. There's people that like it white. There's a bunch of other colors that people change to. The flesh, the F, stands for flesh. So I'll kind of open this thing up. Okay, so you can see this is the new version of the program, and it tells you what each one of these is. So S stands for skin, F is flesh, B is bone, D is dentin, which is more a thing for dentists, E is enamel, and A is amalgam. So, you know, really what we're worried about is flesh and bone as chiropractors, because I'm not checking for any cavities in my office. So these are the two that I mess with. So in this particular case, I had, you know, sometimes you have to play with it. So I've set the 3D at 0. Because when I set it at 100, it wasn't as clear. It didn't make too much of a difference. But for me, I got more definition at 0. So, I mean, you just have to kind of play with it. So that's one of the things you have to play with, is that. All right. So the other thing is I'll always, you know, I change the color. And this is the color palette that I like because it gives me good contrast. So if other people choose other color, I mean, you can do whatever you want. I'll show you. You know, I could change this to blue. So now it's blue. I mean, you know, you can do whatever you want. For me, you know, this is the color I like. And then I change flesh to this dark kind of brown color. Because you need these two to have contrast. So one light and one dark. You know, you could, you know, some people, well, what if I did like white here? And then, you know, you could do it like that too. It still gives a good contrast. I mean, you know, what if you did black here? You know, you could do black and white, but for me, it you know, it loses that kind of 3D. I mean, it's still got the 3D effect. I mean, you know, do whatever you want. You can, whatever gives you good contrast. So for me, I choose this one and this one. And this is the contrast that I like. It's easy on my eyes. That's what I like. So you know, do whatever you want, but so the main things you're going to mess with is the flesh and the bone. And you may have to go, you know, this is what happens if I go 0 bone, because a lot of times it comes in on 0 setting on bone. I usually always put that at 100, and then you can mess with the 3D and see what comes up clear. If you mess with the pixels, it'll go black. So it needs to probably be on 100 here, but these are all the sliders. These are principal sliders that you're going to have to adjust. And then, so if you've adjusted all this, there's still more that you have to adjust. And so you have to come down here on the bottom. And so you may have to grab this little arrow and you're going to click it until it turns white. And then you can, you know, so if the image is all cloudy because you're seeing too much flesh. So you're just going to move the slider until it gets nice and crisp and clear. And you may also have to move the bone. So if it's really dark, then you may have to move the bone until you get it as light as you want. And so, you know, there's not anything that's universal for everybody, but if you're getting lost, these are the basic settings that you need to mess with to get the 3D image as clear as possible. And especially for us, so we can see that contrast on the articulations. All right, so flesh, bone, mess with the 3D. To open up this little setting here on the bottom, you know, and you can even save settings, although for whatever reason I save it and then from my computer, it tends to delete it afterwards, but you could go up into the settings, let's see, and go to the 3D, and you could personalize your settings and save them. There's also here on the bottom, you can save them. There's even a way I think you can save it as a certain name. I mean, there's a whole bunch of stuff here. So this is my actual palette of colors. And there's the original one that came. So I mean, you can save them as different palettes so that you already have it that way. So that's that. So for me, I don't have anything more to present for tonight. For people that, you know, this is the first time that you've logged in and seen a CBCT image, on the Blair site, you can find the whole digital manual that will go through how to analyze using a Blair analysis, how to do a basic orthogonal analysis following more of the orthospinology procedures. And then there's also an HIO toggle analysis, which is also suitable for a majority of the knee chest chiropractors. And so it's very cool. I think it's cool to have all these different backups and analysis. So let's say someone's not doing good with one analysis, then you can do another analysis to back it up. And you know, maybe with one analysis it showed that it was left laterality, and they're not doing good, but with another analysis it shows right laterality. They should match. In the majority of cases, they should match. Obviously, with orthogonal versus articular analysis, there's different landmarks that you're using. So it's not that one invalidates the other. I mean, you're kind of comparing apples to oranges. So, but as far as laterality, if the vertebra has shifted to the left, most of the time, doesn't matter what analysis you do. If you're doing it correctly, it should be the same. But there are some cases where it's really, really small, and an orthogonal analysis may show right, and the articular may show left. But then you have table placement, you have head placement. I mean, there's a bunch of different things. You have the angle of or vector of adjustment. So once again, I think all analyses are valid and they all work. It's just a matter of us understanding them as best as possible. So I will leave it open. If anybody has any questions, ask away and I will be glad to answer.
Jake, where can I find the new link to the new software or the updated software?
Yeah, so people have been telling me, I mean, what happens, I tried to download it a bunch of times. I filled in the thing because in the digital manual, in the CBCT manual, it gives the link and you go in there, you type in your stuff and it says, in 10 minutes, we'll send you a link to your email. I never received one, but some of my students received one and they started playing around and they were sending me screenshots because they were having problems. And I was like, wait, that's not the same version of the program I have. It must be a newer one. And so one of my students sent me the version and I copied it and I put it in the folder inside the Google Drive in the upper cervical CBCT manual. There's a folder that says software. And so there should be 2 versions of the software there. So this version is version 3.10.9. And you can see that the 3D, I mean, it goes way quicker.
Yeah, very cool.
Than before. And so, I mean, I didn't move my trowel. I mean, look how fast it goes. I mean, it goes super fast. It doesn't get stuck, and it's the same computer. On the old program, it went way slower. And there's a few other differences. There's a cool, you know, there's a few other differences, but the main thing is that the 3D goes way faster. And then the bottom, the 3D, you know, where I have green here and all these different colors, it says flesh and bone. Also, that's different. There's a few other differences, but the main difference for me is that the 3D goes quicker. So, but yeah, if you have the CBCT manual, right?
Yep.
Okay, yeah. So go into the Google Drive. There's a little folder that says software. I believe it says software or program. I think it says software, and there should be two programs. So just download it onto your computer, and you're good to go.
Perfect. Thank you.
Anything else?
Oh, that's great. Thank you. Thank you very much, Jake. Excellent.
No problem, Graham.
All right.
Good to see you.
Good to see you.
So,
Good to see you all.
yeah.
too.
So if there's nothing else, once again, thanks Tracy for organizing this. And I'll let her, you know, talk about the next meeting. I think there should be another one next Thursday. I'll let her say that. But once again, thanks Tracy. Thanks everybody for being here. And if you have any questions, you can send me an email, specificchiropractor@yahoo.com, or you can find me on Facebook, Jake Hollowell. Send me a message if you're interested about learning more about CBCT. So thanks a lot, guys.
Thank you.
Thank you.
Hey, thanks, Dr. Hollowell. And
Thank
if you
you.
guys have any questions and you didn't catch that email, you can also shoot me an email as well. But we will be meeting next Thursday at 4 p.m. Eastern Standard Time. That will be presenting, and he's got the crazy time difference from us, so he'll be up bright and early his time in Australia to be meeting with us, and he will actually be going over his thermography. If you have seen his module at all, he's going to go into some more detail about his thermography module and just some different scanning tips and techniques that he has. So if you guys can make it, we hope to see you there. So thanks everybody for coming, and hope you have a great night.
Thanks, Tracy.
Awesome.
Thank you, Jim.
Thanks.
Thank you guys.
Thank
Bye.
you.
Thank you, guys.